Good morning. Thank you for joining us for our KHC office hours today. It is great to be here with you. We welcome everyone who has taken time out of your busy schedules to be here with us today. We have prepared a handout for you of today's presentation, and we will be placing it in a link in the chat. For sound quality, everyone is muted other than our speakers, and we can unmute lines later in the hour for questions and answers. This session is being recorded, and we will have a link posted to our KHC Education Archive later today. We are using our Zoom webinar platform. We encourage you to locate the chat and the Q&A features on your screen. Please use the chat features to let us know where you're joining us from and to add any comments or discussion. When using the chat, please select all panelists and attendees so that everyone can see your message, not just the panelists. If your message is only for the presenters, please select all panelist options. The Q&A feature also has a special role, so let's use this feature to post any questions to the presenters. Next slide. So here's an outline of our time together today. Our featured topic is how to reach and engage physicians to reach your goals on the sepsis bundle. We will then share resources, upcoming events, and next steps for the Compass Age Quick program. And just a reminder, if there's any questions, please use the chat, or you can always reach out to us anytime following this session. Next slide. This is your KHC Compass Age Quick team that's here today. Today we have Erin McGuire, Quality Improvement Advisor, and myself, Heidi Corson. We also have the pleasure of having Dr. Stephen Simpson join us, who I will introduce in just a few minutes. Next slide. Before we get started, I just wanted to show you guys a review of how we're doing as a state on quality improvement work plans. So in 2021, the graph on the left, you can see we had 42 hospitals indicate that sepsis was a priority for them. And a year later, in 2022, 51 of our 92 Kansas Compass hospitals has chosen sepsis as a top 3 priority. So this is a 10% increase in Kansas alone. We also know that sepsis is a top priority for the other states in the Compass network, which is Mississippi, South Dakota, and Iowa. Next slide. And this is just a snapshot of the interventions that hospitals have selected that they are working on. The dark blue represents interventions that are underway. Light blue represents hospitals needing information on interventions. The yellow defines hospitals selecting the intervention but have not started on implementation. And the red is not selected, meaning hospitals did not choose this intervention to work on. So these interventions are listed in order of the most underway to the least. So you can see that many Kansas hospitals have indicated that they're using the 3-hour sepsis bundle, standardized order sets, and early detection screening tools. Next slide. So that was just a little recap of where we're at for sepsis on our quality improvement work plans. So allow me to introduce our guest speaker for today. Dr. Simpson is a 1983 graduate of the University of Kansas School of Medicine. He completed residency training at KU and a fellowship training in pulmonary and critical care medicine at Rush University, Chicago. His professional experience includes faculty appointments at Rush, the University of New Mexico, and the University of Kansas since 1998. He has been a director of critical care at the Albuquerque Federal Regional Medical Center, as well as fellowship director and interim division chief of pulmonary and critical care medicine at KU, and director of the medical intensive care units and chair of multidisciplinary critical care at the University of Kansas Health System. Dr. Simpson is the president of the American College of Chest Physicians for 2020 through 2021. And he currently serves as a senior medical advisor to the Biomedical Advanced Research and Development Authority of the U.S. Department of Health and Human Services. He serves as an expert panelist for the NIH COVID-19 treatment guidelines and co-authors the Surviving Sepsis Campaign guidelines for the diagnosis and treatment of sepsis and septic shock. So I think he's a pretty busy guy, so we're really excited to have him here with us today. And at this time, I will turn it over to Dr. Simpson.
Thanks so much, Heidi. I appreciate that kind introduction. And I will get my slides here up on the screen and we will get going. You can all see, especially as I lecture across the country this year, I'm happy to put this as my first slide in every single talk I give. Now, I hope those of you who are K-State fans won't be offended by this, but it is true. The Jayhawks are national champions for a while. I need to show you a little bit of something about my work with BARDA. So where does BARDA rest? In the Department of Health and Human Services, there is a division called the Assistant Secretary for Preparedness and Response, and we rest right under there. I work in a division called DRIVE, and I work on a program called Solving Sepsis. And that was stood up in 2018 with the intent of stopping sepsis. The reason for that is that sepsis is a health security risk to the nation. ASPR is actually considered part of the nation's security apparatus, sort of like the CIA in a way. Not really, but it makes me feel good to say that. Sepsis, all the potential terrorist threats, all the potential, threats like COVID-19 are security risks to the nation. Because if our soldiers are knocked out by illness, if our citizens are knocked out by illness, it represents a security risk. And so that's why sepsis is important to ASPR and why it's important to HHS. There's a reason I'm telling you all this. These are my other things that Heidi just listed. I am now the immediate past president of CHEST since 2021 has gone by the wayside. I am a senior advisor. I have not had any industry funding for the past 18 years, and that's important for you to know. It's important to me that you know that, because you will know that I'm not telling you anything that's related to pharma or industry. This is why I had to tell you all that other stuff. Nothing that I have to say represents the views of the US government or any other organization that I work with, and I have no conflicts of interest to disclose. That's the important stuff. So we're going to talk about sepsis, reaching and engaging doctors, and in what the folks from KHC sent me, it seemed like our key points for today will be around diagnosis. And if you guys have additional questions or things of interest about the actual treatment, I'd be more than happy to do another segment like this. The thing I love, one of the things I love most in the world is communicating with people how to recognize sepsis and how to treat it rapidly and appropriately. And one of the things out of that bunch of things that I like so much, I like even better communicating with people in Kansas hospitals. It's real important to me. Some of you may know me from the days when I started the Kansas Sepsis Project and used to drive hospital to hospital trying to convince people that sepsis was important. Now, part of the topic here is engaging doctors, and I am betting that most of you who are on the audience are not doctors yourselves. You spend a lot of time looking at your sepsis data in the hospital, and you're trying to figure out how to get doctors to listen to you about making that diagnosis and jumping into the treatments that we know we need to give. Some of you are subject to the CMS regulations or the CMS reporting measures for sepsis. Others may not be in critical access hospitals. I'm not sure whether CMS has extended the requirement to report on sepsis measures to you guys, or whether it comes to you in a different form in your quality improvement programs. The single best way to communicate with a physician is going to have the knowledge at your fingertips and to know where you got it. In the world where I work, in the intensive care unit, from the very first institution of intensive care units, this has been a very team proposition. You know, we count on our nurses, we count on our respiratory therapists to pick up on things, to notify us when there are things. And this is second nature to us, but I understand that in the vast majority of hospitals, frankly, in America, it isn't necessarily viewed as a team sport, and doctors tend to be a little defensive about things like this. So if you're going to speak to a doctor, you have to have good, solid knowledge base, and it's best to know where that knowledge came from. These slides that we're talking from all have references on them. You will be able to see where the knowledge comes from. So as I say here, knowledge is the best form of empowerment, and it is your best tool in speaking to doctors and trying to get their attention. Just a fact of life. We doctors are a different breed of people. I recognize that, and we tend to highly value our own intellectual content and not necessarily want to listen to other people. So you have to have the facts, and you have to use facts that are not alternative facts, so to speak. You have to get straight to the literature. So what's the problem that we're facing here? Our providers, docs and advanced practice providers, are slow to diagnose, slow to treat, and they take disorganized and non-standard approaches to the treatment of sepsis. Doggone it, I forgot to turn on my timer, so now I'm not going to be sure when, when I hit 45 minutes. The root causes of this slow diagnosis is there literally is inadequate knowledge of the signs, symptoms, and findings associated with sepsis. But all doctors, I can assure you, all doctors think that they understand sepsis. And I'll tell you why. It's because they've heard the term sepsis from the beginning of the first year of medical school and all the way through. And often they have not had specific instruction on what that means. And so many doctors still believe that sepsis is only when you have hypotension and you have to give vasopressors, and that's when they think sepsis is. So we have to all be prepared to communicate that isn't just what sepsis is, and here are some better ways to approach it. There's some inertia. A lot of times when the signs are recognized, there is often this notion that patients don't look that sick, even though they meet the criteria for sepsis. There is a resistance to cookbook medicine, and I'm sure you've all heard this one time or another. Patients are all different. I can't use a cookbook to treat my patients. And in point of fact, we can address, maybe if we get to some questions and answers, we can address that issue. And then there's inconsistent messaging, even from national organizations, guideline groups, and government at the present. I'm going to skip by this. You can read it on your own. It's just what we need is for providers to reverse all those things that were on the last slide. So let's talk about what sepsis is and a current definition. This is the way sepsis, the medical body, if you will, critical care docs and so forth, have accepted this definition that was proposed in 2016. I think it was a mistake for us to accept this for reasons that we can discuss later, but nevertheless, this is the new from the third international consensus definitions. This will be our new definition, and we'll get to the definition. What surprised me about this when they came out with it was they said the current use of 2 or more SIRS criteria to identify sepsis was unanimously considered by the task force to be unhelpful, which I thought was just plain silly. And you take some of the top minds in sepsis in the world and put them in a room and they come out with something like this. It's totally ridiculous. I want you to look at this. What do you see here? You see some road rash. If you look carefully, you'll see there is a margin of cellulitis around this road rash, and we don't know yet whether this cellulitis is advancing or not. There's a little bit of pus here in this component. And so this is a pretty nasty looking road rash incident. Now, I tell you, these are the patient's vital signs. Pulse at 75, respiratory rate of 10, and a temperature of 37 degrees. So what do you do? Okay, probably you tell them, yeah, nothing, keep it covered, keep it clean. Let me know if anything worse happens. On the other hand, if these are the patient's vital signs, now what do you do with a pulse of 110 and a respiratory rate of 20 and a temperature of 39.5 degrees? Okay, I just want you to all think to yourselves, what do you do with that? And now I'm not even going to ask, did you choose something different? I'm going to say, why did you choose something different? I want you to think through that. You did because you recognize that the latter circumstance, which is now an infection with systemic manifestations or SIRS, is something more than a simple infection. This is a fairly obvious thing, and I'll show you some data that support that shortly. Even Hippocrates, holy smokes, 3,000 years ago nearly, Hippocrates knew that a local lesion that's heated by humor afflux, whatever that is, makes the whole body become feverish. One can die because of this, especially on odd-numbered days. So you got a couple of things wrong here. We don't know what humor afflux is. Actually, it may be circulating cytokines for all I know. But the odd days, that's a little bit strange. Today, by the way, is the 22nd, so you better keep your eyes peeled tomorrow in case you get a fever, because you could die from it. Hippocrates knew this. He knows that that high fever is a problem. Here is the definition that was proposed in 2016 that you will see is a little bit different from how you are approaching this, especially if you're trying to shepherd the CMS core measure in your hospital. It's life-threatening organ dysfunction due to a dysregulated host response to infection. So let's break that down a little bit. What are the key components of that? Organ dysfunction has to be present under this definition for it to be sepsis. There has to be dysregulation of a host response. Now, here's the problem. Can you look at a patient and recognize dysregulation? I certainly know that I can't. No one even knows what dysregulated means. It just means that something's going on that we don't understand. How that's supposed to help us recognize sepsis is not clear, but it does have to be a host response to infection, and that is of key importance. So the things we can recognize from the outside are an infection that induces organ dysfunction, and this is what the generally accepted definition of sepsis is today. A lot of reasons why that was wrong to be adopted, but it has been. Now, if you are shepherding the CMS core measures, you know that that's not the way CMS defines sepsis. CMS defines sepsis the way we have for 25 years leading up to this new diagnosis. So it seems if all you're doing is looking for infection and organ dysfunction, this ought to be easy, right? But with regards to diagnosis, and actually he wasn't necessarily talking about diagnosis, Bertrand Russell, when he wrote this, but he said everything is vague to a degree that you don't realize until you've tried to make it precise. In other words, when we've tried to define organ dysfunction, when we've tried to define infection, when we've tried to define SIRS, it seems like, oh yeah, this is easy. It's truly easy. Everyone should fall into a box here, but it's a little more vague than that. And let's talk about what I mean by that. So with an infection, wherever it might be, we know that there is a mishmash, and this is only some of the stuff that's happening. There's inflammatory cells in there, they're producing cytokines, there's leakage of the vessels in the area of infection, there's vasoplegia, meaning the vessels can't constrict. And in some infections, this is bad enough that this begins to happen all over the body. And when it does begin to happen all over the body, and some of this stuff leads to dysfunctional organs, then we say, well, this is either sepsis by the new definition or severe sepsis by our older definition. And then if it continues to happen and it gets worse and worse and worse, we get septic shock. The way I said this to a family last week when I was in the ICU is this: their loved one had strep pyogenes, standard stuff you get out of a strep throat, right? When you culture that, had strep pyogenes. And I simply said to them this: it's growing in his bloodstream, the strep. And I said, remember when you had strep throat? Remember what that feels like and how nasty and bad it was just in your throat? Imagine with him having strep in his bloodstream, that's going on in blood vessels everywhere and in organs all over his body. And oh, that turned on a light bulb. They got the picture then of what we're talking about. So when we diagnose sepsis, what are we doing? Look here, you see a big mishmash. This is a big cloud of all these things going on, getting worse and worse and worse. But what we've done is draw a line and say, in this cloud, this line belongs here. Does it really? Is that really the issue that we can definitely separate where infection and SIRS have crossed over into sepsis and severe sepsis? Likewise, is it definitely true that we can tell where severe sepsis has crossed into shock? Is that where you draw the line, or should the line be here, or should it be here? My point is, everything is vague to a degree that you don't realize until you try to make it specific. In point of fact, this is all one process. It just progresses in some people, and in some people it progresses rapidly, and other people it progresses more slowly. But without intervention, in most people it will progress. It's why antibiotics were invented. Now, is it true that everyone with an infection before antibiotics died? No, it isn't. Some people were able to get even to this stage of organ dysfunction and then pull themselves back, but far fewer without antibiotics than survive today, with us being able to knock out the source of infection. But this is why it's sometimes difficult and fuzzy, and we'll talk some more about that. Now, those of you who have heard me talk before know that I never give a sepsis talk without speaking about this man for 3 reasons. Number one, he is the man who looked at a mishmash of different ways that people were defining sepsis and going, wait a minute, man, you're all using positive blood cultures. If I have to wait till the blood culture is positive to say this person is septic, the horse is out of the barn. And he was from Arkansas, so that's probably exactly what he did say. The horse is out of the barn. And so he recognized that there had to be some constellation of clinical findings or a syndrome that we could recognize for sepsis. So we did that. He proposed that, and he was able to convince the entire world, yes, it is a syndrome, and we need to pay attention to these things and drop all this positive blood culture nonsense. Secondly, when I trained at Rush, he was my mentor, Roger Bowen. In fact, he is the entire reason that I went to Rush, so that I could learn more about sepsis and critical care and do it better. So I show him, because without him, without his influence in my life, I probably would not be talking about sepsis now. And number 3, I want you to all know, in case you don't, that when he developed the criteria for severe sepsis and for sepsis, he was an assistant professor at the University of Kansas. So that's even better than being national champions, is coming up with something like this at the University of Kansas. Those are 3 good reasons to tell you where this all came from. You all remember, and I'm sure you know this like the back of your hand, that we are looking for infection, we are looking for systemic inflammatory response syndrome, and then when we see that, we are calling it sepsis. When there is organ dysfunction in the presence of sepsis, we call that severe sepsis. And then when there's hypotension despite fluid resuscitation, we call that septic shock. These are the definitions you're using if you are using the CMS bundles and the core measures. This is your reference, where it came from. Multiple references subsequent to that show that it is an important definition that does have clinical meaning, and we're going to run through some of those things. Don't forget, SIRS is fever or hypothermia, heart rate greater than 90, respiratory rate greater than 20, and a white count that's either too high or too low, or that has too many bands. I know you're used to seeing this. You're searching through charts for it daily if you're a sepsis coordinator. And this, again, is where these criteria come from. And lastly, these are the organs we look at, regardless of what system you have adopted for looking for organ dysfunction. These are the organs that we look at: central nervous system, cardiovascular system, respiratory system, hepatic system, renal system, and coagulation system. Okay, I'm not going to run through all these criteria because I suspect that you have them down by heart. Now, under our old form, we said if lactic acidosis is present in the presence of an infection, that is an organ that's dysfunctional. And I think there's a really good basis for believing that. The new system doesn't use that, but your system that you're using for CMS does, so stick with that. Here again is the third international consensus definitions for sepsis and septic shock. Huge mistake. They only considered, what they did here was they examined several 100,000 patients, and they looked for, in the presence of an infection, which they defined as a person who had had blood cultures or body fluid cultures drawn and antibiotics started. They considered that to be a person with suspected infection. And I think that's a reasonable definition when you're trying to search through charts, finding people like this. So they said, out of those people, what things can we hone in on using machine learning and statistics to say which of the findings are most closely associated with two things: death or prolonged ICU stay. Okay, so the issue that I have, that many of us have with this particular definition, is that it's based on the deadliest forms of infection. And it does not do anything to give us an early warning so that we can intervene when the infection is most treatable. So they dropped the term severe sepsis, and they dropped the use of SIRS and infection, and we'll talk through some reasons for that. So the sepsis 3 diagnostic criteria, and you need to understand the relationship between these two, because some of your doctors are going to have read, well, sepsis 3, we don't care about SIRS anymore. First off, the sepsis 3 authors themselves, even though they said it wasn't helpful, what they meant was it wasn't helpful in predicting mortality, and they were actually wrong about that. And in fact, their own data showed that SIRS is predictive of mortality, and I'll show you that in a moment. Nevertheless, you need to understand the difference. So sepsis 2, we called sepsis the infection plus SIRS. Under sepsis 3, sepsis means infection plus a change in SOFA of greater than 2 points. SOFA we'll come to. Severe sepsis is non-existent under the new form. We used to say it was infection plus SIRS plus organ dysfunction, although we also said if SIRS is not present, but you have infection plus organ dysfunction, then you have severe sepsis. Again, this is the equivalent of this. Infection plus SIRS plus organ dysfunction, almost identical to infection plus a change in SOFA points. Septic shock, we used to say, is infection with unresponsive hypotension. I apologize. We now say it's infection with unresponsive hypotension and day serum lactate. Again, there's still considerable debate over exactly what the right definition is. This is the SOFA score. Do not memorize it. I don't memorize it. I calculate it every time referring to a table like this. But again, with lungs, cardiovascular, liver, renal, coagulation, central nervous system, the SOFA score just drops out the lactate for reasons that are not entirely clear to me. Also, how do we assess the CNS on the Glasgow for SOFA score is via the Glasgow Coma Scale. This is the Glasgow Coma Scale. Again, you will be able to refer to this should you desire to. And so how do you get SOFA points is by toting up your Glasgow Coma Scale score. So that makes this rather inefficient, rather difficult to use, actually, is the fact you have to do this. They knew it would do that, so they looked for, is there some way we could tell quickly if somebody's really sick that we can do at the bedside without sending any labs? And what they figured out was this thing they called the quick SOFA or Q-SOFA, that if you have any two of these three things, that yeah, you are likely to progress to prolonged ICU stay or death. So it makes a good screener for mortality. Does it make a good screener for sepsis? We'll talk about momentarily. But so any Glasgow Coma Scale less than 15, and what that means is anything other than a patient who's awake, alert, and oriented person, place, time, and situation. Okay, so essentially any mental status change. Respiratory rate greater than 22, systolic blood pressure less than 100. All of these, of course, are available at the bedside, and so they thought this would be easy to use. I didn't stick this in the talk, but in the surviving sepsis guidelines that we released in 2021, we warned people against using this as your principal sepsis screener. Why? Because it identifies people still who are late. It helps to separate who's going to die from who isn't going to die, but not who has sepsis that needs treatment from who doesn't have sepsis that needs treatment. The emphasis then with this stuff about SIRS is that we've supposedly shifted from inflammation to organ dysfunction in our attention, that requiring SIRS to diagnose sepsis, this is, I'm certain this is the people coming to my house. I'm gonna try and make that go away. Requiring SIRS to diagnose sepsis misses cases of infection-induced organ dysfunction. That is likely true. We'll go through that, but there's a big but to that. And it's not specific to sepsis. I climb a set of stairs and I get SIRS. These are the big arguments against using SIRS. We'll take them one at a time. The emphasis has shifted from inflammation to organ dysfunction. In point of fact, it has not. This is the original 1989 description of the sepsis syndrome. And straight from here, I have taken that evidence of inadequate organ perfusion or dysfunction was a key component of what we thought sepsis should be. There it is from the very beginning. We put it in as severe sepsis. I've got so many things to say on this topic. And so I talked to some of the people who were at the original, very first sepsis conference. And what they said was the original consensus conference was set up for several purposes. Among others, one was for uniform definitions, and another was to try and diagnose septic patients who were being missed, and if possible, at the earliest possible stage. The entire reason that we have sepsis, severe sepsis, septic shock is trying to have a category of people who have not yet gotten to life-threatening, that if we intervene before they get to life-threatening, we can perhaps reduce the mortality. And Charlie Sprung was there, Bob Balk was there, some people who are still alive and around were there. The point is, infection with SIRS was intended to prompt you to search for organ dysfunction. This is a key thing for you to remember if doctors push back on SIRS. The intent, the reason it's there is to prompt you to look for organ dysfunction. So you pick up severe sepsis, or what we now call sepsis, so that you get it early. The second thing, requiring SIRS to diagnose sepsis misses cases of infection-induced organ dysfunction. So this is a paper that was published by the Australia and New Zealand Critical Care Society, published in 2015 in the New England Journal. And they looked at everybody with infection-induced organ dysfunction. And what they said was that, you know, SIRS is only present 87.9% of the time. So it's not a very sensitive test. And I went, well, you know, actually 87.9% is really quite sensitive. So to criticize SIRS because it isn't always present when there's organ dysfunction is actually rather silly. They even showed in their own data that if you had SIRS with your organ dysfunction, this is percentage who died, that it's more deadly than if you have organ dysfunction without SIRS. Isn't that interesting? The unadjusted mortality showed that the more SIRS criteria you met, the more deadly was your sepsis. So a lot of people have looked. I didn't put in here, I was probably the first person to put in the literature, this is a mistake to make this change to sepsis 3. But there have been multiple people who've looked now, enough for a meta-analysis to show, hey, this new definition of sepsis, it does a good job of separating who's going to die from who isn't. But in terms of finding who's going to develop organ dysfunction from their infection, it does a poor job. In that case, SIRS does a better job of finding. So what they said was SIRS significantly superior to Q-SOFA for sepsis diagnosis, and Q-SOFA slightly better than SIRS in predicting hospital mortality. The association of both criteria could provide a better model. So this is the difference. It's why SIRS remains important. So as I say, you know, requiring SIRS to diagnose sepsis misses some cases, but the truth is we have always said, if you have infection and organ dysfunction, you have severe sepsis, we used to say, now we say sepsis. But yeah, whoever said you have to have SIRS, it basically is what we call a straw man that they were trying to knock down. And SIRS not specific to sepsis, a lot of doctors are going to tell you, we can't use SIRS because I climb a set of stairs and I get SIRS. And again, I can't argue with that. You get tachycardic and tachypnic if you climb 3 or 4 flights of stairs. But what they're forgetting there is the entire definition from the beginning didn't say known or suspected infection. What they originally said was clinical evidence of an infection site. That becomes a lot easier because what kind of clinical evidence are you looking for? Pneumonia, cough with a sputum production, a fever, pleuritic chest pain, and consolidation on exam. You can call that a pneumonia without having any microbiological test, without anything else. I can make the diagnosis of pneumonia. Cellulitis, fever with painful skin and an advancing red margin, pyelonephritis, flank pain, and costophrenic inguinal tenderness, and on and on. Go looking for, when you see SIRS, go looking for evidence of an infected site. Some sites are a little harder, like a bloodstream infection seemingly out of nowhere, but a little cut, a scrape, a physical opening in the integument or in the bowel can allow bacteria in and allow for bloodstream infection. People with immunocompromise, sometimes they present and you can't tell what the infected organ is, but you got to know when they're immunocompromised that it may be more difficult to tell. An isolated mental status change even fools me sometimes. Had a lady in the ICU last week who was there recovering from an episode of sepsis, to be honest. But she had intermittent confusion, intermittent delirium. She got better for a day, and we were going, great, what we're doing is working. Then she got worse again. I didn't chalk it up to sepsis again until later that afternoon. She got a fever to 40 degrees Celsius. And then I went, oh, you dummy, isolated mental status change. You know that that is an important sign of sepsis. Fungal infections often sneak up on you, even sneak up on me, because they're indolent and they take their time building to a crescendo. And all of a sudden the patient's in septic shock, when it had just been a little of this and a little of that, and these can be difficult. Bayes' theorem, this is a lot of numbers to throw at you. Basically, I almost feel like skipping it, but basically what it says is, what's my probability of having sepsis if I have SIRS? Well, Bayes' theorem puts it in mathematics, and we say, okay, we know that it's the probability of having SIRS if you have sepsis, which we now know to be about 88%, times the probability of sepsis in the group you're looking at. And this is the key important thing. Do I look for sepsis in people that just climbed 4 flights of stairs? Not in the least, no. Do I look for sepsis in somebody who felt sick enough and bad enough that they came to the emergency department, put themselves in my hands and said, something's wrong with me, I need help? In that group of people, if SIRS is present, do I think it has a different meaning? Yeah, absolutely. So Bayes' theorem just simply says, look at the context. What is your context when you see SIRS? Is there something else that should be causing SIRS to be present? Or is it that this could be an infection, and go looking for it? We've known since the 1990s that there actually were consequences to SIRS. And in fact, this was done in the University of Iowa, and they showed your mortality just from having SIRS goes up. But what if you have infection-related SIRS? Goes up even further. So SIRS is associated with mortality. And in point of fact, these are the data from the Sepsis 3 paper that show, look at this, the more SIRS criteria you have, the more likely you are to die. So even their own self-professed criteria of what means you're more likely to die, they chose to ignore that having SIRS is associated with mortality if you have a suspected infection. Not only that, using SIRS helps you to diagnose earlier. This is 3 different proposals: Q-SOFA that I told you about, SIRS that I told you about, and something called the National Early Warning System that's used in the National Health Service in Great Britain. What they did was they said, what was the time point? Time 0 out here is the time point at which patients either were moved to the ICU or died. What they showed, what this line is showing, is the 50th percentile, the median time before time 0. And what they showed was that SIRS detected this 17 hours before the need for move to the ICU. Q-SOFA detected at 5 hours, NEWS detected at 12 hours. Why is this important? All of you are working with sepsis. All of you know that getting antibiotics in a person, getting fluids in a person, getting the other things done that you need to do, it doesn't just happen like, you know, snap your fingers and it's all done. It takes time sometimes for us to marshal. It takes time for us to find an open ICU bed sometimes. It takes time to get the antibiotics from the pharmacy. Less so if you're in a critical access hospital, I'll grant you that. And I think you guys do a great job of getting antibiotics in folks in the main, once you recognize sepsis. So that's the key thing. So how do we proceed with all of this information? We need to look for the infection. If you see SIRS or you see Q-SOFA, neither one of those identifies an infection. In fact, it's a common mistake looking for fevers in every infection, But when you do see them, go looking for the site of infection. If you see infection with SIRS, we need to treat people and we need to look for organ dysfunction. If we see infection in Q-SOFA, we need to treat people. We need to look for other organ dysfunctions. It's really that simple. So this is all the information I think that we have to get across to our docs. I pushed myself to go fast so we get to this. To recap all of this, probably the single most important thing in this talk is that the Jayhawks are national basketball champions, by the way. Thank you for letting me talk. I'm going to stop my things here. I tried to go relatively quickly so that we can have some Q&A, and I hope you guys are happy to do that, because sometimes the best stuff comes in the Q&A.
Yes, it does. Thank you, Dr. Simpson. We really, really appreciate your time today. And thanks again for making the time for us. I'm going to turn it over to our audience and give them opportunity to ask you questions while we have you.
Cool. And by the way, I want to say to people too, I am a national authority in this area. You are welcome to refer your docs to me anytime. Tell them to pick up the phone and call me. I'm available and happy to discuss a patient and why this might be sepsis. Anything in the chat, maybe?
I'm not.
Did I bludgeon you into submission?
I see a question. It says, can you speak to refocus exam by the provider to meet the 6-hour bundle and what we look for to ensure we are meeting it?
Okay, to refocus the provider, yeah. So again, knowledge is going to be your companion, and I would say you want to have these criteria and what the 6-hour bundle is. You want to have it. I'd carry it around on a notebook and say, here's directly from CMS what they are looking for. What we just went through there. Anytime you see mental status that's off, anytime you see SIRS present, anytime you see evidence of an infection, you have to go looking for the potential organ dysfunction. And this is what we need to get communicated to our docs, both in the emergency room and most especially, I'll tell you where it's hardest for doctors, is the people that are already in the hospital with one thing or another. Because their mind is focused on this thing. This person came with an acute cardiac event. Everything about them should be explained by their acute cardiac event, rather than, hey, this person came, they've had an IV for 4 days, those IVs can get infected. I need to be thinking about something new. It's really hard for folks to refocus from the original diagnosis to a potential new one. I don't know if I've gotten to the root of your question, but again, if I were able to speak to all of your providers, I would say to them exactly what I just said to you, which is these things that are off should prompt you to look for other things. Why should they prompt you for this? You know how many cases of sepsis there are in the US every year? Over 1.7 million. Over 1.7 million. Sepsis is the single most costly condition that we treat in American hospitals. It is the single most common cause of death in every hospital in the nation. Between 35 and 45% of people who die in a hospital will die from sepsis, whether they came to the hospital with it or whether they got it in the hospital. 35 to 45% of people. It's so common, so important. It's got to be at the forefront of your mind, not at the back of your mind. We have done a couple of things in American medicine that are useful, important, but we've convinced people that fluids when you have heart failure is terrible. It'll give you pulmonary edema. And we have convinced people to start looking for pulmonary embolism in folks that are short of breath. I find that over and over and over. Our own emergency department at KU, the number of cases of sepsis that are diagnosed because they thought they had hypotension from a pulmonary embolism and sent someone to the CT scanner and found pneumonia instead of a pulmonary embolism are, more than I can count on these hands. I mean, they happens all the time. There has to be a sensitivity to this diagnosis because it is so common, and it's deadly if you don't treat it right.
Another question from Joe Stevenson. She commends you, excellent presentation. They are in the process of initiating a nurse-driven protocol for early initiation of core lab, IV, etc. Do you think this will be helpful to not have to wait on provider assessment, which may be 10 to 30 minutes after nurse assessment?
Yes, it certainly can be. It isn't always, and you always have to watch. Where'd you say Joe is from?
Joe's from Pratt Regional Medical Center.
Yeah. Okay. So couple of different things. You will learn as you use the screening tool that oftentimes you pick up stuff. You pick up SIRS first. Honestly, SIRS is the easiest thing to find, right? Somebody's tachypnic, tachycardic, breathing fast. I already said tachypnea, didn't I? Febrile. That's easy to pick up on, and it will flag your screen. Where you have to be smart if you're running a nurse-driven protocol is then for the nurse to assess that patient. Instead of just going, hey, we have SIRS here, this must be sepsis. You have to assess the patient and be sensitive to the things that I just said. You got to say, hey, is this patient infected or not before you call your doc. If you call, we discovered this. We have EMR flags, that we've tried for a decade to use these EMR flags. The only time it was successful, it was never successful if the EMR flag for SIRS and organ dysfunction went off to the bedside nurse and to the doc simultaneously, because so many times it was wrong. It was picking up something that wasn't an infection and then told everybody about it. The time it was successful was when we put a coordinator in between the flag and the bedside folks, so the coordinator could look and go, yeah, this looks like there's an infection present. Let's go ahead and notify people. So that's going to be your big thing when you put the screening tool in place, is recognizing when it's infection-induced SIRS and when it isn't. But as long as you've got a mind, a thinking clinical mind to make that assessment, then yes, I think it will be very useful for finding early people. And in fact, this was the component of the surviving sepsis guidelines that I was in charge of, and we looked at the data and we know that a formal organized screening program picks up more people sooner and saves lives. And we recommend that every hospital does that.
Two more questions here to answer. One here in chat. What's your response to a provider who says, this is cookbook medicine and I don't practice that way?
Yeah. Cookbook medicine, it's what they always say. And probably they're really talking about the cookbook when they talk about, should I give fluids? Should I give antibiotics? And again, that will be another talk that we will talk about, but these are based, if you go to the 2021 Surviving Sepsis Campaign Guidelines, which you can get, by the way, you can download at survivingsepsis.org. They're provided free to anyone who wants them. If you look, you will see that these recommendations for antibiotics are based on actual data in actual patients. We all know that every patient is different. We also do know that taking a standardized approach saves more lives than otherwise. This is a fact. It's not made up by someone, that a cookbook. Okay. Secondly, between you and me, your doctor has a cookbook in his or her head already. They have their own cookbook. They're like your grandma making biscuits, right? She knows what she's going to put in the biscuits and they turn out yummy. And she'll tell you, I don't need a cookbook, but She's got her standard operating procedure, and every doctor has that for any normal condition. Some brand new condition that we've never heard of, like SARS-CoV-2 in 2020, nobody's got a cookbook for. But or red herrings, rare diseases, they don't. But stuff they see day in and day out, pneumonia with sepsis, they've got their own cookbook in their head. It's just that we know from data that if you approach it this way, more people will survive, period. That's the between you and me. But what you have to drive them to is the surviving sepsis guidelines, which are all based in scientific evidence, all based on clinical studies that show improved outcomes. And then you can say, hey, these people don't practice by cookbook either, but what they do practice by is having a standard operating procedure that they know is the most effective, and only deviating when a patient actually deviates, when a patient shows you that you should deviate. Making it up on the fly for every new patient is just quite simply not an appropriate way to practice medicine. And they're not making it up on the fly, they just are. This is a saying that's gotten into doctors' heads, and they all believe that they're treating everyone individually in a personalized way, when often what they're doing is not treating anyone individually in a personalized way. That doesn't help you, because you can't say that to your doctor, but just keep pushing them and push them on the notion. Very, very carefully, we assess the medical literature to find out what's the best approach. And that's the approach taken by the Surviving Sepsis Campaign guidelines. And you can keep pushing him to those.
And our last question, we have an issue with our providers utilizing rule out as a stage of sepsis. What are your thoughts on that? Is there a definitive line where sepsis is present to get rid of the rule out thought process? In addition, their documentation never reports whether they've ruled it in,
whether they did or didn't, yes,
or out, but they're treating the rule outs for sepsis.
Yes. Yeah, well, first off, your doctor should know this. They can't get paid, nor can the hospital get paid for a rule out diagnosis. If they haven't learned that by now, I don't know when they're going to learn that. You write down, there is no such diagnosis as rule out. It's not. I challenge you to find that in the ICD-9, ICD-10 codes. It's not there. Possible sepsis, now that's a different animal. And if they write possible sepsis, that's something that they can even be reimbursed for. So if doctors don't, if doctors don't understand anything else, they understand that if I can't get paid for it, I probably shouldn't be doing it. So I would get with your coders and make it clear to these doctors that rule out doesn't mean anything. If you're ruling it out, it means you don't think they have it. So nobody's going to pay you for taking care of it. Now, so that's one thing. The next thing is possible sepsis should lead you to the steps to determine whether it's there or whether it isn't. And here, quite simply, is where it doesn't matter whether the doctor thinks it is or isn't. What matters is what it turns out to be, right? Because when you're evaluating this for CMS, what you're doing is looking at all the facts and saying, well, the doctor should have, by this point, should have been able to make the determination. Okay, all of that. Now, if you want to say to your doctor, you can stop saying rule out, or you can stop saying possible, is if you thought it was enough of a possibility to send blood or body fluid cultures and to start antibiotics, then it was sepsis. It is sepsis. That is exactly what the sepsis 3 criteria determined to be sepsis. And if you're doing CMS, that would mean severe sepsis. But interestingly enough, it turns out that making up your mind, it's not hard to make up your mind. Is there organ dysfunction here? That's pretty simple. If somebody's confused, there's organ dysfunction. If somebody's hypotensive, there's organ dysfunction. Liver enzymes are up, there's organ dysfunction, et cetera, et cetera. That's pretty simple. What's often most difficult for people is deciding, do I think this is present because of an infection? If they have thought enough of that they're sending cultures and starting antibiotics, that it means they've thought through it well enough to make the diagnosis of sepsis. If it turns out that you never get an infection, that doesn't even matter. Why it doesn't matter? Because nowhere in anybody's book does it say we have to have a positive blood culture. We have to have a positive culture of some kind or another. It only says, I think it's a high likelihood that this infection, there's an infection present here, but I may not be certain right now in the emergency department, but that's okay. Then how do I judge as a doctor whether an infection is or was not present in the emergency department? Two things. One, if they respond to antibiotics, bingo, that's great. Two is if any of my cultures are positive, bingo, that's great. Sometimes you don't get those positive. In fact, blood cultures are only positive in 17% of sepsis cases, okay? So you often don't get the positive culture, but you have to rely on the response to antibiotics. I hope that was useful. I know you're not able to talk back to me, so you can't say, no, that wasn't exactly what I was getting at with any of these questions, but I hope that's useful. I am happy, by the way, to do this anytime. In fact, we could have a session sometimes that's just me and you guys come with what your stumbling blocks are on the SEP1 measure, and we can talk through how to approach those. I'd be more than happy to do that. I know I can't monopolize the KHC's presentation times, but I'll soak up as many as they will allow me to.
Well, we will definitely take you up on that, Dr. Simpson. And for the sake of time, it is a little past the top of the hour. So we appreciate everybody's time. And if you have to log off, go ahead. I'm going to go through some updates, and it will be recorded so you can go back and look. And Dr. Simpson, we understand your time is just as valuable. So if you need to log off, you're more than welcome to do so. In a recap, Heidi will send out your contact information if that is okay, Dr. Simpson. For any follow-up questions, they can email you directly. Absolutely. And we can always visit with you about bringing you back on at a later date to do some SEP1 discussion follow-up. We again appreciate it and thank you for the valuable discussion. I'm still seeing message and chat come through about how appreciative your time and discussion was today. So thanks again, and we appreciate it and look forward to continuing our discussion.
Glad to do that. And my final reminder, don't ever forget the stuff on these slides. It's data, it's real, it's what you can always go back and rely on when you have to talk to somebody who chances are doesn't even know what the data are that you're discussing. They just think they do. All right, I'm going to go ahead and log off. Thank you, everybody, for having me. I really appreciate it.
Thank you. Have a good day.
Bye-bye.
Okay, Phil, you can go ahead and move to the next slide. Eric couldn't be with us today, so I am your Eric for the next couple of minutes. Just Eric has recently completed the data refresh on June 10th. So the data reports have been sent out. Check your inbox. The next refresh is scheduled for on or around July 8th. Please shoot to have your QHI data entered in for May and submitted by July 1st. Next slide. There is the next QHI training session is scheduled for June 29th from 1 to 2 p.m. The link to register is provided here on the screen, as well as available in today's handout. Next slide. Don't forget about this wonderful quality reporting guide for critical access hospitals. Our friends at KHA and QHI worked so hard on this. You can download a copy by following the link provided. It's shown on the slide as well as in the handout. I can't say enough great things about this guide. It's wonderful, wonderful, wonderful. Next slide. Just move right into some resources here for you. This is included in today's handouts as well. It's a copy of a new tool that was just recently shared with us by our friends at Convergence. Surges in hospitalizations, staffing shortages, and limited family visitations can increase the risk that patients experience harm during a hospital stay. The summer's coming compilation includes tips on ways to layer on protections against common harm events such as readmission, sepsis, CAUTI, opioid stewardship. There's even a great page on patient and family engagement. You'll want to check this out. Next slide. Office hours is going to be on summer vacation for the month of July, so no office hours next month. Our topic when we return in August is going to be around the health equity organizational assessment. And then do remember that all of our sessions are recorded and then are posted to the KHC Education archive. Next slide. We hope that you were able to join us for the first 3 sessions of the Antibiotic Stewardship Practical Implementation for Kansas Hospitals. The 4th and final session of the series is going to be held on July 7th at noon Central Time. Each session is approved for 1 nursing and/or pharmacy and continuing education credit. See your handout for more information. Next slide. And then the next Quality Corner call is on August 10th. The topic is to be announced soon. You can watch the CROP website for more information. Next slide. Couple save the dates for you. The first one here is the 2022 Kansas Opioid and Stimulant Conference. It's going to be an in-person event this year, first time in 2 years. It's going to be held in Topeka on November 10th. So look for more information soon. And then the next slide here is plan to attend our Summit on Quality. This too is going to be an in-person event in Topeka on August 19th. An invite should hit your email here pretty soon. Next slide. And then some next steps as you leave us today. Make sure that you are staying up to date on your data entry. Make sure you're reviewing and updating your 2022 quality improvement work plan. Don't forget to reach out to Heidi or I for support. Don't forget to take some time, log into iCompass or iCompass Academy, engage and learn alongside with your fellow Compass HQuick peers. And then the next Compass Navigator is going to hit your email on July 1st. There will be lots of learning opportunities that will be linked in that newsletter. Next slide. If you are interested in participating in the CARE Collaborative program at the University of Kansas, please reach out. Jody is the executive director of the CARE Collaborative, and then Karen, I'm not even going to attempt her last name. She is the sepsis program manager. She has lots of information for you. Please feel free to email. It's a great program, lots of resources and great support. The program is of no cost to your facility. So I would encourage you just to reach out for more information. And then of course, our contact information is included. I will skip over questions for sake of time. You can always find Heidi or I, and we'll answer those questions for you. Please take a couple minutes out of your day, answer the survey questions here. Let us know how we did, how we're doing, and what you thought a key takeaway was from today. Next slide. Just remember, office hours is on vacation next week or next month. And then thank you so much for being with us today. Enjoy your day, enjoy your week, and stay cool, everyone. Bye-bye.